Now, before doing anything, we're going to go over the 5 main types of antibiotics that are available to you in the hospital. I would say learn these main 5, and then you can learn all the other weird and wonderful ones, and I've mentioned some of them at the bottom. Medicine's been revolutionised by antibiotic therapy. It was probably pioneered from 1928. There are 5 main classes of antibiotics. Antibiotic resistance is rising alarmingly in hospital. We're having to change our antibiotic protocols every year. And you must also aim for the narrowest spectrum of antibiotic possible. So there are beta-lactams, there are macrolides, fluoroquinolones, tetracyclines and aminoglycosides. They all do different things and some of them have cross-reactivity. With beta-lactams we're talking about penicillins and we're talking about cephalosporins. They inhibit cell wall synthesis. They are the most common antibiotics and most allergies, 10% chance of anaphylaxis associated with this group. Resistance can occur by bacteria synthesizing beta-lactamase, and that's why tazocin has tazobactam and coamoxiclav has clavulanic acid, and they reduce the chances of bacteria synthesizing beta-lactamase. Beta-lactams exhibit time-dependent killing mechanisms, and so the time above the minimum inhibitory concentration, that means the amount of bactericidal agent, so the amount of antibiotic in your blood required to cause an inhibitory effect on bacteria is of key importance. So the time above that concentration is of key importance so they need time around the bacteria to actually kill them. And this is at contrast to other antibiotics which work in a concentration dependent way, and we'll talk about that in a minute. You want a higher level over a longer period of time essentially for the beta-lactam to work, and that's the rationale with IV antibiotics, and that's why they're more frequent. So gentamicin you'll see once daily, because it has effect beyond the time in which its serum concentration is above that minimum inhibitory concentration, whereas beta-lactams need that high concentration. That's why you can give tazocin 3 times a day in some people. You can give tazocin 3 times a day to keep that serum level high, whereas gentamicin only needs once daily dosing. It is better. They are in general, beta-lactams, better for gram-positive bacteria such as the cocci like staph, strep, and bacilli such as Clostridium and Listeria. Piperacillin, for example, extends into a gram-negative killer for Pseudomonas. That's like tazocin. So tazocin was developed to combat the rise of Pseudomonas infections, and that's why it's used with tazobactam to prevent the beta-lactamase, and that gives us tazocin. There's 5 to 10% cross-sensitivity between cephalosporins, which are also beta-lactams, and penicillins, so the allergy can be brought on, so you can't just go, they're allergic to penicillins, can't give them tazocin, but I'll give them a cephalosporin. It doesn't work like that. We use beta-lactams in throat, skin, chest, surgical prophylaxis, meningitis, biliary and intra-abdominal sepsis, and we'll go over some of the regimes you might use in the hospital after we look through this infograph. The next section is macrolides. Macrolides are drugs like erythromycin. They are protein synthesis inhibitors. They disrupt mRNA. They include erythromycin, azithromycin. They're mostly gram-positive, but some gram-negative effects. They exhibit time-dependent killing mechanism, the same as beta-lactams, as we've already discussed. Unlike the beta-lactams, they work against chlamydia, Legionella, mycoplasma, and mycobacteria. They have a slightly wider spectrum than the beta-lactams, so they are substituted for those with penicillin allergies. They work on gram-positive bugs like strep pneumonia and gram-negative bugs like Haemophilus influenzae. They're used in respiratory, skin, soft tissue, sexually transmitted, H. pylori and atypical mycobacterial infections. Moving on to the fluoroquinolones. Anything with fluoxetine at the end is a fluoroquinolone. Broad spectrum, it inhibits topoisomerase and leads to DNA fragmentation, gram-negative and gram-positive cover. Multiple problems with fluoroquinolone resistance, unfortunately, occurs very fast because there's high veterinary use of these drugs such as ciprofloxacin, levofloxacin in veterinary practice, so the resistance of bugs to them is very high. Its use is mainly regulated to community, so the newer generation such as levofloxacin is going to be used in the community most, and in penicillin allergies you can use them in hospital-acquired pneumonias. It's used to combat Legionella and mycoplasma pneumonias. They're atypical and they're sort of seen in urinary antigen screens, so ciprofloxacin's an old drug, levofloxacin's a new drug. Beware of the drug interactions and prolonged use. Exhibits concentration-dependent killing mechanisms, so the higher the dose of it, the better. And that's concentration-dependent killing mechanisms. So the higher you can get your serum levels at any given time, the better, where it's safe to do so. Action beyond the minimum inhibitory concentration can be seen. So whenever serum levels fall, whenever the drug wears off, you can still see action of the antibiotic on the bugs below the minimum concentrated serum level. Uses of fluoroquinolones include hospital-acquired pneumonia, community-acquired pneumonia, Legionella pneumonia, typhoid fever, meningococcal prophylaxis, and anthrax prophylaxis. Tetracyclines are used. We probably have most heard about them used in acne, such as oxytetracycline in the community. They're broad-spectrum antibiotics. They inhibit protein synthesis by 30S subunit ribosome binding. Gram-positive and negative. They have time-dependent killing mechanisms like the beta-lactams, but they have moderate after effect once their serum levels fall under that minimum inhibitory concentration. It was used in the Indian plague outbreak in 1994, so it was useful against plague. Resistance has risen markedly due to the bacteria inheriting a ribosomal protection pump. We use tetracyclines in rickettsia, Q fever, Lyme disease, chlamydia, acne, chest pneumonia, malaria, anthrax, cholera, plague, and syphilis. Aminoglycosides are very commonly used in hospitals, such as gentamicin. They are bactericidal. They are protein synthesis inhibitors. They inhibit ribosomal bindings irreversibly. They are gram-negative in action, most of them, and they have some anaerobic action. But you might, if you suspected anaerobes, you might want to give gentamicin plus something like metronidazole, which is a good anaerobic killer. They include drugs like gentamicin, amikacin, streptomycin, neomycin. Concentration-dependent killing, like the fluoroquinolones, so the higher the dose, the larger the efficacy, and you will see strong irreversible binding of the drug to the ribosome, and that really sort of explains why you see effects at the bugs after the gentamicin level has fallen below its minimum inhibitory concentration in the blood. So the effect of the drug lasts far beyond the drug has, demonstrably worn off the serum concentrations. Daily serum levels are needed for dosing, and dosing charts in hospitals should be available. It is not used in Neisseria gonorrhea or Neisseria meningitis or Legionella due to endotoxic shock potential. And what happens is, because they're bactericidal, they kill the bacteria, and they essentially cause the bacteria to dump all of their endotoxic contents into the blood and cause shock. There's still concerns over ototoxicity and nephrotoxicity, so it can damage your kidneys and damage your ears if given the dose. So if you give a dose of gentamicin fast or too large a dose of gentamicin, it can cause ototoxicity, deafness, and also kidney damage. Its uses are in complicated or catheter-associated urinary tract infections, hospital-acquired pneumonia and aspiration pneumonia, severe intra-abdominal and neutropenic sepsis. Some of the other weirder ones within the antibiotic spectrum that's used in hospitals. Linezolid, for example, is a protein synthesis inhibitor. You see it has good gram-positive action against VRE, MRSA, skin. It's used in skin infections and pneumonia. It's got very good penetrance, so it's used in skin infections where you're, for example, penicillin allergic and you've got a worsening cellulitis. Aztreonam inhibits cell wall growth in bacteria. It is good gram-negative cover against E. coli, Haemophilus, Klebsiella, Proteus, and has a very similar mechanism of action to penicillin, and indeed there's crossover between penicillin, the beta-lactam, and aztreonam, so in terms of allergy you need to be careful. Metronidazole is a nitroimidazole. It inhibits nucleic acid synthesis. It is anti-protozoal, so for protozoas it's used, and it's effective against anaerobes. Tazocin, as we already know, is a broad-spectrum beta-lactam. It inhibits cell wall synthesis. It is used for gram-positive and negative bugs, and it was developed for the rise in Pseudomonas infections. Chloramphenicol, protein synthesis inhibitor. It's used for eye drops. It's used in bad meningitis, cholera, typhoid. It covers gram-positive and negative. It unfortunately has a very nasty side effects of giving a lot of hematological disturbances, such as agranulocytosis and aplastic anemia. Cotrimoxazole, it causes folate synthesis inhibition. It is a combination of trimethoprim and sulfamethoxazole. It is used in PCP, PJP pneumonia, which is very typical pneumonias that you can sometimes see in patients who are immunocompromised with conditions like HIV or AIDS. It's also used for MRSA skin infections. Vancomycin is a glycopeptide. It's cell wall synthesis inhibitor in gram-positive only. It is only used for gram-positive things. It's used for skin, blood, heart infections, MRSA, and particularly this day and age, C. difficile. It can be given orally as well for C. diff. Clindamycin is a lincosamide. It's a protein synthesis inhibitor. It is very, very similar to macrolides. It is used for anaerobic chest, skin, dental, and periodontal infections. Tetracycline is a protein synthesis inhibitor. It is a broad spectrum antibiotic. It's used in complicated skin, soft tissue, intra-abdominal osteomyelitis. It is a orangey colour. It's given over a long period of time because it has good penetrance into bone. Very few antibiotics have very good penetrance into your bone, and it's one of the ones that you can be on for a long period of time in an attempt to get rid of osteomyelitis. In this video we're going to be looking at the principles of antibiotic prescribing. Antibiotics are an everyday occurrence in the hospital, and you will be dealing with this a lot in your foundation jobs. One of the first things to consider in the septic patient that you're considering antibiotics on is sepsis 6. We'll go over those in a minute. You should know those off by heart. The second consideration is you culture. You take blood cultures, you do sputum cultures, you send atypical urinary antigens, you culture urine, you do skin swabs, everything. The nurses will be doing this as well, culture, because this allows you to start on a broad antibiotic regime as per your hospital policy, and we'll be going through a example hospital policy shortly, and it will allow you to move broad antibiotic cover to narrow antibiotic cover as soon as those culture results come back. You review all antibiotics, all empirical antibiotics, at 48 to 72 hour mark, and you always look to see whether you can switch an IV antibiotic into an oral antibiotic. Something to go over quickly is the concept of what a blood culture bottle actually is. So you start by filling the aerobic section of a blood culture bottle first, and as we know, blood culture bottles look something like this. And you have aerobic and anaerobic bottles, so you normally do them in pairs. Don't take off the labels that are on the side of them and stick them in the notes, as a lot of people do. They're used by the labs to identify the bottle. What then happens is whenever you send them off to the lab, a microbiology tech will come along and spike the top of that bottle with a CO2 sensor. The CO2 sensor goes in here and then off to the machine. What happens then is they're put in an oven that keeps it at body temperature, and as any bacteria that you filled this with, so you filled this with blood at this point, 10 to 15 mils of blood, so that's full of blood mixed in with the nutrients within the solution that's already in it. And what happens is then, as the bacteria multiply and grow, they will give off carbon dioxide. The carbon dioxide within here then triggers a positive on the CO2 sensor, and once that positive is identified on the machine, then the microbiologist will look at this with a fine tooth comb and see what bugs might be growing in it. This is called an early identification sample, so you will see, for example, gram-positive cocci clusters, and therefore you will get a gram stain, and you will also maybe get a preliminary idea of what the bug is that is growing in the person. So this is a good thing to do properly. You clean the tops of these before you draw blood, and this should be done with sterile gloves in an aseptic non-touch technique as per your hospital policy. But we'll move on to the actual prescription of antibiotics now. So the first disease to talk about is meningitis. Meningitis with an unknown etiology should be treated first of all with a second generation cephalosporin such as ceftriaxone. Ceftriaxone is given 2 grams BD intravenously. The second, in a penicillin allergy person though, you would give chloramphenicol 25 milligrams per kilogram IV QDS. Once again, these are from a hospital protocol. They may not be your hospital protocol, so always follow your protocol, and these are just examples of safe drugs to say in an exam rather than safe drugs to actually give. So these are exam sensitive answers. So ceftriaxone and chloramphenicol will both cover a broad range of meningitis-causing organisms such as Neisseria meningitidis. Ceftriaxone and chloramphenicol are both prized because they transverse neural membranes well. So essentially, you might think, well, why can tazocin or something similar not be used in these patients? And it's because of the penetrance of the drug into the CNS. So ceftriaxone and chloramphenicol both represent drugs that can penetrate the CNS and get to the site of action where they're needed to combat the microbes that are causing the meningitis. If there is immunocompromise in the patient, you might want to consider adding in amoxicillin for broader cover. And adding in cotrimoxyl furoate typicals, and that would cover things like PCP and pneumocystis cover, such as cotrimoxyl, also called Septrin. The doses here are purely examinatory, and you must check everything that's in this video in the BNF. If with meningitis there is a cross consideration that they might have encephalitis, you would consider giving a acyclovir. And acyclovir is usually given at about 10 milligrams per kilogram 3 times a day intravenous. With intra-abdominal infections such as diverticulitis, cholecystitis, etc., less than 48 hours post-admission, which means they're just admitted to hospital and it's not a risk that it's a healthcare associated infection, you would start these people on amoxicillin where they are not penicillin allergic. If they were penicillin allergic, you would substitute amoxicillin with teicoplanin. You would add in as well, so you would put them on triple therapy. You would put them on amoxicillin 1 gram TDS, you put them on metronidazole 500 milligrams TDS, that's for anaerobic cover, gentamicin IV as per the protocol, and that is for your gram-negative cover. So amoxicillin's for gram-positive, metronidazole is your anaerobic cover, and gentamicin IV is your gram-negative. If this was happening 48 hours post-admission, or they were post-surgery, or they were post-op, basically post-admission, either greater than 48 hours post-admission, or they have had a recent hospital admission within a month, you would commence the person on tazocin, which is a broader spectrum. It's a broader spectrum beta-lactam. It's basically the escalation from something like coamoxiclav, because it is tazobactam and piperacillin. Within it, that's 4.5 grams TDS unless they have renal compromise. You would also add in gentamicin for a good gram-negative cover. There is gram-negative cover within tazocin, but it's not very good, and this just completes your broad spectrum cover. Second line would be tetracycline and gentamicin if they were penicillin allergic. Oddly enough, this is the same regime as you would consider in somebody with spontaneous bacterial peritonitis as well. So spontaneous bacterial peritonitis might also get this cover of tazocin and gent, and tetracycline and gent as second line. Just always beware of antibiotics and allergy crossover. So for example, amoxicillin is obviously a beta-lactam, so you can't give it to somebody with penicillin allergy. And same with tazocin is also penallergic. And anything that's a cephalosporin, such as ceftriaxone, ceftaxidine, all those things are all beta-lactam based and cannot be given to somebody with penicillin allergy. In the same vein, you should always check with senior members of staff whether an allergy is appropriate. Check with the patient what the actual allergy was, whether they had anaphylaxis or characterize it, and then discuss to see whether you can actually give them penicillins. But if they have a documented penicillin allergy, don't give them anything that can have crossover with penicillins, and that includes amoxicillin, tazocin, penicillins themselves, and cephalosporins. Even other antibiotics can have some crossover with beta-lactam, so it's always best to look up your drug policy in the hospital. In an uncomplicated lower UTI, you may want to consider not using antibiotics at all, but where they're indicated, if the patient's becoming unwell with them having temperatures, etc., you might want to consider drugs like nitrofurantoin or trimethoprim in the first instance. Both are good against E. coli, which is the largest culprit of lower urinary tracts in females, and the treatment duration for females is 3 days and men 7 days, and that's for the duration of your antibiotic therapy. If you have a complicated UTI, such as pyelonephritis, urinary sepsis, you would start them on tazocin and gent, and second line in penicillin allergy would be ciprofloxacin and gentamicin, all IV. In a sepsis of unknown origin, if you don't know where the culprit is and the person's severely unwell, sepsis 6 has already been done, and you've identified this patient as having a surge response, or they're becoming more unwell with dropping blood pressure, pyrexias, increased white cell counts, and if you had something like productive sputum or foul urine, you could actually treat that as your main source. But if you don't know what it is, you should cover empirically with broad spectrum powerful antibiotic like tazocin and gentamicin. If they have a penicillin allergy, you might want to use teicoplanin, metronidazole and gentamicin. That will give you gram-positive, gram-negative and anaerobic cover, the same way that tazocin and gent would. So that tries to equivocate alternative antibiotics, but you'll never truly get as good antibiotic cover as if you weren't penicillin allergic. It's better to not be penicillin allergic because it limits the antibiotic choices you have, and you end up having to add in more. The next consideration you should have in these patients, are they neutropenic? If you're considering such a thing as neutropenic sepsis, you would cover them with tazocin and gent, which is the same as sepsis of unknown origin. And as a second line, you might want to try meropenem, and you try meropenem at its maximal dose. Eventually, but probably the best way to use meropenem in the first instance is 1 gram, and that's 1 gram TDS IV. But that can be escalated to 2 grams. But at this stage, you'd be speaking to senior people. If the person was very sick, you'd be speaking to a hematologist. If there was any sort of pulmonary focus, you might want to add in clarithromycin, which will cover you for any atypicals. So that's clarithromycin, and that's usually given at 500 milligrams BD orally. The reason it's given orally rather than IV is because it has the same effect if you give it orally or intravenously. So we choose to give it PO rather than giving the person another needless intravenous antibiotic. If you thought there was an infection at a central line source, which is central venous catheter CVC, you might want to add in teicoplanin. If you thought the patient had necrotizing fasciitis, of course you would organise an urgent surgical review of the patient, but you would start them on meropenem, and that's usually 2 grams. That's the escalated dose TDS IV. And you would also start clindamycin, that's usually at a dose of 900 milligrams TDS IV. And that is because of their penetrance as well. So meropenem is very good broad spectrum carbapenem, and clindamycin has good skin penetrance as well. Beware that meropenem has crossover with beta-lactams and should be used in penicillin allergy. If the patient simply had localized cellulitis, however, you might want to start them on flucloxacillin. You might want to start that at an oral dose, potentially 500 milligrams QDS PO. And second line clindamycin, and an equivocal second line is clarithromycin. Both of those are suitable in penicillin allergic patients, and are both fairly good for skin penetrance. Fluclox is the best, but if you thought you had moving infection where it was getting worse and worse, spreading systemic infection, significant cellulite, you would give an increased dose of flucloxacillin, 1 gram QDS IV, so that's different to the 500 QDS PO. If they're penicillin allergic, you might want to consider the usual clindamycin, clarithromycin IV or PO. Clarithromycin be given orally as well. Linezolid is another antibiotic. It's normally given about 600 milligrams BD orally, plus or minus gentamicin. Gentamicin can be added in to any of these therapies to give good gram-negative cover, so it can be added to the flucloxacillin, clindamycin, clarithromycin, or linezolid, which is one of the newer antibiotics that has excellent skin penetrance. This is for a spreading infection with signs of systemic infection.